Virud, Assistant Professor in Department of Urology. We will be discussing one interesting case in Clinico-pathological Conference. Case is Mr. X, 50-year-old gentleman, a chronic tobacco chewer since last 25 years, with history of diabetes mellitus and hypertension since last 9 years, presented with chief complaints of right flank pain since last 2 months. Patient was apparently well 2 months ago when he noticed right flank pain, mild to moderate in intensity, non-radiating, associated with nausea and vomiting. He had similar complaints on and off, but the pain was relieved with medications. He had history of fever with chills in between. There is also history of difficulty in urination. Rest, there is no history of lithuria, pyuria, hematuria, or there was no history of loss of weight and appetite. He had history of suprapubic catheter placement for stricture urethra 8 years ago. He also underwent end-to-end urethroplasty for stricture 8 years ago. That could be the cause of his voiding difficulty currently. His BP and sugars were controlled with medications. With these complaints and examination, we further examined the patient. On general examination, his general condition was fair. He was averagely built and well nourished. There was no icterus, cyanosis, clubbing, lymphadenopathy, or pallor. Systemic examination was within normal limit, but on digital rectal examination, there was grade 1 firm non-tender prostate. There was a supraprostatic bulge was palpable on right side on DRE, but the overlying rectal mucosa was free. So with this in mind, we have kept a differential diagnosis of renal stone, likely a ureteric stone because he had a intermittent right flank pain. Then there is a chance of urinary bladder mass with right VUJ involvement, right lower ureteric mass, seminal vesicular mass, and these are rare possibility, but these are kept in mind before evaluating the patient. So he underwent ultrasound KUB in August 2023, which showed right kidney grossly there was a gross hydroureteronephrosis with parenchymal thickness of only 2 mm, and there was echoes and debris in the PCS, indicating there was some infected pathology. Left kidney was normal. Urinary bladder, a solid growth of size 2.5 by 2.5 centimeter was seen in right perivesical space invading lower end of right ureter. And there was loss of fat planes with right posterolateral wall of urinary bladder wall. So suspected malignancy was given and prostate was 27 cc. Rest investigation were normal except kidney function test. He had creatinine of 4.8. Maybe it could be due to his prolonged diabetes and hypertension. And also right kidney is having hydronephrosis. Further, urine RM showed proteins, sugars, and pus cells 100 to 120 and RBCs of 50 to 60 per high power field. Rest investigation like urine for malignant cytology, which we regularly do in urinary bladder mass or ureteric masses, it was negative, and other etiology, GUTB, again urine for AFB was negative. In view of abnormal kidney function test, the patient was decided to undergo non-contrast CT because contrast CT cannot be given in CKD patient, cannot be done in CKD patient. So I call Dr. Taruna to further discuss the NCCT QB findings.
Good evening, everyone. So just to recap the history, 50-year-old male patient with history of right flank pain and bladder mass detected on an outside ultrasound. He had elevated urea and creatinine, so a non-contrast CT scan was done from outside. You can see the images here. So this is the right kidney, which looks hydronephrotic. This is the right kidney, which looks hydronephrotic. As we see here, the left kidney is normal. There's no hydronephrosis on the left side. Right side hydroureteronephrosis is seen. And you can see a mass in the right lower ureter, which is also involving the right posterolateral wall of urinary bladder. And if you see very carefully, you can see some tiny foci of calcifications as seen here and here. This is the seminal vesicle calcification. So the fat planes with the right posterolateral bladder wall and seminal vesicles were lost. And this you can see the mass in the coronal images and in the sagittal images here. After this, patient also had a history of chyluria. So another study followed, which was MR lymphangiogram, in which we inject contrast into the bilateral inguinal lymph nodes, and we trace the contrast tracer into the lymphatics of the pelvis and lower abdomen. So here you can see in the 5 minutes, the right lymphatic channel and the left lymphatic channel is pacified with contrast. We also do delayed imaging to find out the causes of the chyluria. And you can see here the contrast was seen already in bilateral lymphatic trunks going up to the mid abdomen, and the left kidney is normally functioning. So you can see the contrast excretion from the left kidney, but the right kidney is not seen because it was non-functioning. And even in delayed images, we could not exactly find out the cause for the chyluria in this patient. And you can see the rest of the lymphatics on the both the sides, right side as well as the left side, as well as the retroperitoneal lymphatics. You can see very clearly till here, but we could not identify the cause of chyluria on the MR lymphangiogram. Patient also had undergone a PET CT, which was done outside, which suggested that there was a malignant mass involving the bladder wall with right VUJ involvement and hydroureteronephrosis. He did not have his CD available with him at that time. And he also came for a next investigation, which is MRI, and before that, he had undergone TURBT, and the histopathology was suggestive of atypical papillary tufts with granulomatous reaction. So for characterizing the bladder and the ureteric mass, MRI was performed, and these are the representative MRI images. Here you can see this is the bladder. This is the right posterolateral wall of the urinary bladder. You can see some asymmetric thickening in the bladder involving the anterior wall as well as the right lateral wall. The patient also had a history of stricture urethra, for which he had undergone urethroplasty. That kind of explains the asymmetrical bladder wall thickening. You can see this mass is very dark on T2, and the mass is also extending along the right seminal vesicle as well as the right vas deferens here, as you can see on the coronal images as well. On the T2 fat sat images, you can see the mass is actually epicentered in the right lower ureter, but the fat planes with the right posterior bladder wall is not maintained, and you can see the mucosal thickening, associated mucosal thickening in the bladder as well. There was no ascites, there was no lymphadenopathy. On the diffusion weighted imaging, some patchy diffusion restriction was seen in the right seminal vesicle and within the mass, very heterogeneous areas with some T2 dark through effect that we can see. On the T1 weighted images, you can see the mass is slightly hyperintense as compared to the rest of the bladder wall. So slightly hyper to iso-intense mass. And when we give contrast, you can see there is significant enhancement, very early enhancement involving the bladder and the ureteric mass. As you can see, this is the hydroureteronephrosis, this is the ureter. The epicenter of the mass is outside the bladder, so somewhere in the lower ureter, as you can see here. So this is the bladder mucosa that you can make out, and this is the mass with the DJ stent in situ, with associated thickening of the bladder wall also, reactive bladder wall thickening, both seen on axial as well as coronal images. No lymphadenopathy. To summarize all the findings, there was a right lower ureteric T2 hypointense mass with adjoining bladder wall thickening along with right seminal vesicle infiltration with right hydroureteronephrosis and non-functioning right kidney with normally functioning left kidney. So the possible differentials on imaging are right lower ureteric transitional cell carcinoma with osseous metaplasia, and the possibility of granulomatous etiology is also there. Okay, now I would request Dr. Deepak to tell you the further management.
So with this finding, we had differential diagnosis of lower ureteric mass or urinary bladder mass. So before intervention, any major intervention, we try to confirm our diagnosis of ureteric masses, which is also called as upper tract TCC. So we decided to go in and see what we can find and whether it is possible to take some biopsy from the bladder or ureteric mass and send for cytology and biopsy. So patient underwent cystoscopy. Patient underwent cystoscopy. On during urethropscopy, there was a stricture for which we did optical internal urethrotomy. Then there was a grade 1 prostate with normal bladder neck, and bilateral ureteric orifices were visualized and were orthotopic. And approximately 3 by 3 centimeter extramural swelling was seen in the right lateral wall, superlateral to the right VUJ, and overlying mucosa was normal, suggesting that it is not from the bladder origin, maybe from extramural source it could be coming out. So we decided to do a ureterorhinoscopy, and we put a URS scope into the right ureter. Lower 4 centimeter ureter was unhealthy, and we could not make out if there is any growth or any abnormality which is suspicious of malignancy, but it is strictured and there is a it is narrowed because of either pathology or stricture, external compression. So what we did resect the bulge which is present in the right posterolateral wall, and after resection we could reach the tumor. So some part of the tumor was sent for the histopathology, but it was not that conclusive. It was just showing granulomatous inflammation, and all AFB and all other things were negative. So again we were not anywhere. We did not know what is the diagnosis. On post-operative one, he had milky urine, suggestive of chyluria. The investigations like urinary chylomicrons and triglyceride, they were slightly raised, giving a more suspicion of chyluria. So patient underwent MR lymphangiography, which Dr. Taruna has already discussed. There was no point suggestive of any communication with urinary tract, of lymphatic system with urinary tract. So that the urine cleared with conservative management, and patient was discharged on post-op day 3. In view of above finding, because we did not reach with the histopathology of granulomatous inflammation, and as PET CT also showed and MRI also confirmed that it is a malignant mass and right kidney is already non-functioning. So generally with imaging it can be seen that it is arising from the right lower ureter. So treatment of upper tract or masses is generally right nephroureterectomy with removal of the bladder cup. So we have decided to let the patient undergo right lap nephroureterectomy with right pelvic lymph node dissection. So during surgery, again CPE similar findings were noted, and in laparoscopy there was a grossly pyonephrotic right kidney with thinned out renal parenchyma. There was single renal artery and single vein, and there is a large firm mass of approximately 4 by 4 centimeter circumferentially involving the right lower ureter, and also involving dome and posterior wall of the bladder was noted, and it was also involving the right seminal vesicle. Mass was excised in toto along with the cup of bladder and the lower ureter, and right pelvic lymph node dissection was done. So this was the specimen. So you can see the mass. Along with this, there is a bladder cup, and from that bladder cup, the digestant is coming out. All along kidney, ureter, and the bladder cup is removed. So drain was removed on post-op day 3, and patient was discharged on perurethral catheter because we keep it for 3 weeks for bladder to heal. Now I call Dr.
Good evening, everyone. So in this case, we received the resected specimen. So this was the resected specimen we received. This was the kidney, ureter, and urine part of urinary bladder. And this is the cut section of the kidney. So we can see that the parenchyma is completely atrophic, almost cortical thickness is reduced, and there is markedly dilated pelvic ileal system. And also we can see here there is granular necrotic material is present. These features are almost like in the stage finding. And then we saw the gross at the lower end of ureter, which was sampled as tumor, sent as tumor. So we can see the central part, this is the ureter, the lumen, and around that there is pale brown to pale brown areas, right, or almost measuring 4 cross 3 centimeter, and it is encircling all around the ureter. This was present, and here we can also see the ureter which is passing through the mass. This is the microscopic finding, low power magnification. So what we can see in this, that this is the ureteric lumen lined by the urothelial lining, and then this is the wall of the ureter, and all around the ureter there is some deposition of material, right? There is some eosinophilic material which is deposited. You can see all are eosinophilic. Blue area are very less. So blue area correspond to the nuclei mainly. So all area are eosinophilic here, and it is around all around the ureter. Okay. And this is also seen around the detrusor muscle. These are the part of detrusor muscles, and the tumor is also seen around the detrusor muscle. Sorry, this material. And this was the resection margin. Adventitial soft tissue was present, and beneath that there are some similar type of material was present. On further magnification, we can see these are bright eosinophilic material which are acellular, right, without any significant cellularity, we can see, right. So this is present, and with this morphology you can also see significant giant cell response. These are the giant cells which are forming around this eosinophilic material. So they are very confluent, very much. And this is pH stain. So this material was pH negative, weak pH positive, you can say. And on mesenteric greenish hue is present in this material. So with this we suspect possibility of amyloid, and we have done Congo red stain. So this was the Congo red stain. So we can see the Congophilia which is present. So we further confirm by doing polarizing microscopy. And this is the polarizing microscopy which shows beautiful apple green birefringes, golden color. So they are present. And when you compare to the normal tissue, like this is the tissue where no amyloid is present. So if you polarize this, you cannot able to see that type of finding, right? So that's how we differentiate amyloid. So further one close-up view how it looks on polarizing microscopy. So this is the picture of amyloid on polarizing microscopy of Congo red stain section. So beautiful apple green birefringes are present. And this is the another picture which we have taken using direct immunofluorescence microscopy using TRITC filter. So you can see the amyloid negative area, and this is the amyloid positive area. Okay, so very beautiful staining is present. And then we have done serum amyloid A IHC to further subtype what type of amyloid is present. So this is negative for serum amyloid A, and then lambda and kappa, these are light chains we performed. So these amyloid deposits were positive for lambda light chain, while kappa was negative. So this was case of localized amyloidosis. And then this is the photo, low power magnification. This is the part of seminal vesicle. So you can see that the deposits are away from this particular area. So they are not deposited in the seminal vesicle. and lymph node was sampled, so it shows mainly reactive changes. Nothing was found, no tumor was found. And this is the part of ureter which is located proximal to the mass. Okay, so you can see that the lining is denuded, almost flattened, and significant inflammation and hypertrophy of the muscle fiber are present, which are the all features of obstruction which are present. Similar finding on high power, you can see significant inflammation, hypertrophy of the muscle layer. This is the ureter which is located proximal to the mass. Then the section from the kidney shows significant inflammation which was present. Pelvic ileal system was completely ulcerated and covered with necrotic debris. As we can see on high power, these are all acute inflammatory cell, degenerated cells. So this is almost like acute pyelonephritis type of thing. And then this is, again, you can see necrotic areas, degenerated inflammatory cells. So this is all necrosis which is present in the pelvic ileal lining. And the cortical area shows completely globally sclerosed glomeruli. This you can see extensive fibrosis and completely sclerosed glomeruli all along. And on further magnification, we can see, although we could not find the lesion of diabetic nephropathy in this, but yes, most of the glomeruli in this case was globally sclerosed, so it may not be possible. And the vessel shows arteriosclerotic changes. One vessel was sampled, and we can see significant atheromatous plaque formation in the intima. This is the plaque formation, so there is definitely a feature of atherosclerosis in this. So with these findings, we made a diagnosis of amyloidoma of lower urinary tract and acute on chronic pyelonephritis. So just a few points about this entity. So we all know amyloidosis is a protein misfolding disorder which is characterized by abnormal aggregation of beta-pleated fibrils in extracellular location, and it appears as pale eosinophilic acellular material on routine histopathology. And the classical diagnosis is made by demonstration of apple green birefringes on polarizing light microscopy of Congo red stent section. And to date, up till now, 42 pathogenic proteins are known that can produce amyloid fibrils. And this amyloidosis can be localized and systemic, and in most of the cases, we usually encounter systemic form of amyloid deposit, such as light chain or AA amyloidosis. Hereditary forms are also described like fibrinogen and transthyretin forms. Now, amyloidoma. What is amyloidoma? Amyloidoma is a form of localized amyloid deposit which is present as mass-like lesion. That's why it can easily be confused with malignancies. It is reported in virtually every anatomic site such as respiratory tract, urinary tract, GIT, skin, head and neck, bone. So anywhere these lesions are described. And most of the cases of amyloidoma are light chain restricted. Only occasional cases of AA forms or other forms are described. Unlike systemic amyloidosis, localized amyloidosis have no clinical evidence of monoclonal protein that we encountered in light chain related amyloidosis. Because these patients are often asymptomatic, they can be confused with malignancies. The pathogenesis which is postulated for amyloidoma formation is that in this there is chronic and recurrent mucosal and submucosal inflammation which can lead to the chronic inflammation with influx of lymphocytes and plasma cells. And some of these plasma cells over time can become monoclonal and they can produce aberrant type of light polypeptide chains which have tendency to form amyloid fibrils. This is one article. You can see they have described 11 cases of localized amyloidosis which mimics neoplasia, and in this case the author described that all cases presented as mass lesion prior to histological examination and clinically suggested a neoplastic pathology. And in this case, you can see that 7 cases are located in the urinary bladder, 2 were located in ureter, and 2 were located in renal pelvis. And the clinical symptoms were mainly hematuria and mass. Irritative symptoms were also present in some cases. And also, in most of the cases, whenever IHC was done, most of them were light chain related amyloid deposit. And this could be kappa light chain also or lambda light chain also. And most of the cases were followed up, and none of the cases, except one case, none of the cases showed progression to systemic amyloidosis. So this case was on follow-up developed systemic disease, but this was only single case in this whole cohort. And this is another large cohort of localized amyloidosis of urinary bladder, where author described 31 patients. And in this, the age 22 male and 9 females were included. age range 28 to 80 year, and 77% of these patients have gross hematuria, 23% has irritative lower urinary tract symptoms. Cystoscopy impression before biopsy was indeterminate bladder lesion in 8 patients, neoplastic pathology in 6 cases, inflammatory lesion or cystitis in 3, tuberculous ulcer in 1 case, and malakoplakia in 1 case. Diagnosis of amyloidosis was not suspected in any of these patients based on cystoscopic appearance. IHC was done, of which 24 had light chain amyloid deposit, while 3 shows transthyretin reactivity. And none of these patients had systemic amyloidosis. And further workup for monoclonal, systemic monoclonal disorders were done. For light chain monoclonal protein, immunoelectrophoresis was performed. Only one patient has IgG lambda monoclonal protein, but this patient already had TTR form of amyloid deposit. Second case has IgG kappa monoclonal protein present in immunoelectrophoresis, and bone marrow contained 15% plasma cell consistent with MGUS. But in this condition also no systemic amyloid deposition on rectal biopsy or fat aspirate. None of these areas shows amyloid deposit. So again it was localized form of amyloid. Bone marrow biopsy was performed in 7 patients, 5 had normal finding. 1 patient has features of early B cell lymphoproliferative disorder, but again this case do not have evidence of systemic amyloidosis. And second case was similar, that has 15% plasma cells, but no systemic amyloidosis. Treatment in this case, 17 patients underwent transurethral biopsy with fulguration or laser therapy, 8 cases underwent transurethral resection of lesion, 3 cases had partial cystectomy, 1 had total cystectomy, and 1 patient received dimethyl sulfoxide instillation in bladder for initial treatment. 1 patient was not treated. But in this cohort, the author noted that there is very high risk of recurrence. Almost 54 cases on follow-up shows recurrence of this lesion. And this is a very nice review which highlighted, which combined different studies, case report and case series. Almost 184 cases were included in this review, of which 150 were localized form of amyloid and 34 were systemic amyloidosis with bladder involvement. And in this, complete endoscopic resection was feasible in 89%, but again the author highlighted almost 35% cases the lesion recurred. And due to frequent and early recurrence of patient with bladder amyloidosis, the author advised regular cystoscopy should be done and recurrence should be managed with transurethral resection, while intravesical instillation of DMSO and cystectomy should be reserved for refractory cases. So in conclusion, localized amyloidosis of urinary tract as an isolated finding is a rare disorder. It can be easily confused with carcinoma. Histopathology is the only definite way of diagnosing these lesions. IHC subtype determination is helpful, and most cases are of light chain subtype. Repeated evaluation for systemic amyloid are unnecessary in these cases. Progresses to systemic form of amyloid deposit is very rare, but it should be excluded. Early eradication with fulguration or laser therapy is preferred when possible, but transurethral resection or partial cystectomy might be necessary for larger lesion. Regular cystoscopy follow-up is necessary. Thank you.
So with this surprising diagnosis in our hand, further we decided to rule out systemic versus localized amyloidosis. As such, patient did not have any features of systemic amyloidosis. So patient underwent a 2D echo which showed a normal left ventricular systolic function and LVEF of 60%, left ventricular hypertrophy. It could be due to because of he is having prolonged hypertension. His 24-hour urinary protein were in nephrotic range, 9,400 per day. So further, patient was evaluated in general medicine to know whether it is systemic or localized. So he underwent a serum protein electrophoresis which showed hypoalbuminemia with increased alpha-1, alpha-2 microglobulin. There was no AM spike, and beta-2 microglobulin, kappa free light chains, lambda free light chains all were raised. But it does not indicate that it is a systemic amyloidosis because it is non-specific. All things are raised And to having all this condition and to rule out the multiple myeloma, other investigations were done, but there was no M spike. So, but the last thing which is very important, which tells that it is a systemic amyloidosis, fat pad biopsy. This is awaited, and likely he will also undergo a bone marrow biopsy to know whether the bone marrow aspirate also have amyloid or plasma cells. So, with overall this thing, we made the diagnosis of isolated amyloidosis of right lower ureter, as no other signs and symptoms of other organ involvement is present. Follow-up, he has completed 6 months of follow-up. He is on regular cystoscopy, and imaging will be planned to see for any local recurrence. The localized amyloidosis, the treatment of choice is complete resection, and if the complete resection is done, then patient can be considered as cured. But there is a high chance of recurrence at the local site. So patient has to be kept in regular follow-up, sometimes till 10-15 years also. And if there is a recurrence, it should be treated aggressively so that it does not spread anywhere. Thank you.
Any questions?
Suppose the kidney function was normal, then what could have been your plan?
If kidney function would have been normal, we could have done a CT urography only rather than undergoing letting him undergo MR urography or PET CT and all, because CT would have solved all our means what we needed. It would have told.
For local excision, you could have done like uretrectomy and then reconstruction.
Yes, but I think right kidney was already hydronephrotic and not salvageable, so it has to be taken out.
No,
and
in this case, it was fine.
yes.
Otherwise,
Otherwise, also we could have taken, because it is a large mass and it is involving more than 2 centimeter of tumor. It indicates that is a possibility of high risk TCC. So without having any diagnosis in our mind, and we requested intervention radiologist to get biopsy, because after TURBT also it was not conclusive. So but intervention radiologist said ki we are not getting any window to take the biopsy, so you better go ahead with open surgery and take biopsy. But then we decided, as we are treating this as malignancy, we should take all of the thing together.
and do you think the stricture was secondary to amyloidosis of the urethra?
No,
No.
I don't think so, because it was 8 years ago, and if it would have been there, stricture was not resect. It was just end-to-end and urethroplasty was done, so it would have recurred by this time. If it would have been amyloidosis, certainly it would have been there must be a recurrence by this time, and that time ureter was normal. There was no mass lesion.
This time
above.
urethra was normal.
Yes, this time there was a mild stricture which was dealt with OIU.
Okay, nice presentation.
There are no any more questions. We can close the session for now. Right.